Thank you for the invitation. I guess my slides are up. So I don't have any disclosure for coronary work. So these are my objectives. So I'll be giving you a panoramic view on the latest evidence from TCT and ABC Congress. I'll touch base on all of those points. So we'll start with CABG versus PCI in left main and bifurcation. So lately, FAME3 study investigators published in circulation the outcomes of FFR-guided PCI versus CABG with the interaction between true bifurcation versus non-true bifurcation lesions. And just to give you a reminder that the FAME3 trial was FFR-guided PCI for 3-vessel, excluding left main disease, versus CABG. CABG was superior in terms of revascularization, reduction. In this sub-analysis, the authors did not find any interaction between true bifurcation and non-true bifurcation. Just to say, to mention that the use of intravascular imaging was very low in this trial. At TCT, the investigators of Noble trial, they published the 10-year mortality outcomes. Noble trial was PCI for unprotected left main with an average syntax score of 22 versus CABG. The primary endpoint was superior in CABG in terms of reduction of vascularization. But here they looked at 10-year mortality outcome. Just as a reminder, 88% of the population had bifurcation left main disease. A lot of them underwent two-stent technique, 30%, and most of them had IVUS either performed before or after PCI. At 10 years, there were no more difference in mortality between CABG and PCI. So this is a very hard endpoint that was not different between PCI and CABG. So now we'll move on to imaging versus angio guidance. As we know, October trial looked at OCT guidance for complex PCI versus angio guidance. OCT was superior. Here the author looked at specifically the left main lesion population, which was about 19% of the whole population. So a lot of those patients, as you can see, underwent two-stent strategy, more than 70% of the patients. And IVUS was used in 1/3 of the patients in the angio arm. So looking at OCT feasibility for left main, so it was feasible, but as you can see here in the red box, that the visibility of proximal edge was poor using OCT. And here are the outcomes. The minimal stent area was about 7.6 millimeter square for ostial LAD. As you know, there is new evidence to support a bigger stent area, which was published by our Korean colleagues in their multi-center registry that showed that lower than 8.1 millimeter square of LAD area was associated with major adverse events in their population. So going back to October, unintentional stent deformation was observed in 20% in the cornea, okay? That's substantial number and mostly seen in the edge of the left main stent. So and that was associated with increased MACE compared to no stent deformity. Looking at the whole population, OCT versus angio showed a trend of reduction in outcomes if you divide them into left main and disease bifurcation or any left main treated, but that as the sample number was not big, you cannot see significant differences. So what about dual versus single stenting? So this is a pooled data from ABC main trial and Rolex registry, which looked ABC main trial, as you know, is the provisional stent versus bifurcation stent, which showed superiority of provisional stenting in left main disease, while Rolex is looked at the use of Resolute in left main disease. So the pooled data showed that single stenting was associated with reduced events, and specifically revascularization, target vessel revascularization. Such outcome was less seen if we use imaging guidance for dual stenting and single stenting. DK Crush looked at the use of DK Crush as two-stent technology and compared it to provisional stenting. The authors presented their meta-analysis of IPD and included a large number of patients from multiple trials, which re-illustrated that potentially the only two-stent group that showed superiority over provisional stenting was DK Crush and showed reduction in TLF at 6 years. Multiple registries were pulled together from Korea and Italy, which increased the patient volume or patient data, level data to 6,500. And this was actually presented at ABC this year, looking at left main bifurcation and non-left main bifurcation outcomes. In general, in this study, true bifurcation lesions was stated with increased MACE, okay? But if we take a look at the stent strategy, one stent versus two stent was actually not associated with difference in true bifurcation, but the overuse of two stent strategy in non-true bifurcation was associated with increased major adverse events. What about CT angiography? I think this is gaining momentum lately. What about its use in bifurcation lesion? As you know, CT angiography can be used for choosing the perfect guide, choosing the proper calcium modification technique, and choosing the proper angulation, the angioangulation, and the proper placement of stent based on flow, reserve data, and the size of the stent. So that will be looked at the P4 randomized controlled trial, and hopefully we'll have results based on CT-guided PCI versus IVIS-guided PCI, looking at non-inferiority of MACE. This is their approach, and I think this is just to illustrate specifically for bifurcation might be useful because you can measure the volume of mass that is will be at risk and if we occlude a side branch, so you will have a good judgment in either treating versus leaving the side branch. As we know, DCBs has a very frequent wins lately, and actually it made it into the guidelines for some of the consortium and statements, and made it also for in the guidelines for the use in provisional stenting to DCB, the side branch, and this is supported by randomized controlled trial. DCB only strategy can also be used in Medina class 001 and 010. So this is a randomized trial called DCB BEF for bifurcation, where they looked at patients who underwent provisional stenting. If they had more than 70% of stenosis, they will randomize them to drug-coated balloon versus non-compliant balloon, as shown here, and they will undergo rescue stenting if needed. So DCB utilization was actually associated with reduced major adverse events, mainly TLF, at 1 year, and also a secondary endpoint of spontaneous MI at 1 year. Same thing, these are colleagues from Japan, led by Dr. Ishihara, looked at the use of DCB after routine kissing balloon inflation. And the primary outcome here, they looked at restenosis at 9 months of more than 50%, and that was seen less in the DCB arm. It was around 20% the non-DCB compared to 8% the DCB. No differences in hard clinical endpoint. So what about kissing versus no kissing? This is an ongoing topic. This study looked at pod kissing pod versus pod side pod, and looked at OCT data in the main vessel and provisional stenting. You get more expansion with at the bifurcation core and distal main vessel with pod kissing pod strategy. No differences in stent eccentricity But when we look at clinical outcomes, this is data from the ultra bifurcate registry that routine kissing balloon inflation versus no final kissing balloon inflation in provisional stenting was not associated with reduction in MACE. Maybe there's a role for it in real true bifurcation lesions. So in conclusion, second generation drug-eluting stents with the use of modern bifurcation technique imaging guidance can lead to improved outcomes in true bifurcation and protected left main. Imaging is a must to optimize outcomes for one stent or dual stent techniques. Provisional stenting is still the gold standard, and I think if you would like to use two stent technology, DK Crush has some evidence to support it in selected true bifurcation lesions. I think in the future there's a great momentum about the use of pre-interventional CT, and hopefully there will be data to look into that. DCP has a lot of great wins, including its use in side branch and provisional stenting, and also for treating at least Medina 001 or 010 anatomy. The jury is still there for routine kissing, final kissing balloon inflation. Thank you.